We know that PCI improves outcomes for patients with acute coronary syndromes. Door-to-balloon times for ST elevation MI are now standard fare, and many studies have shown that PCI works in unstable patients. But what about patients with stable coronary disease? Meta-analyses have concluded that there is no benefit of PCI in preventing heart attack or death in patients with stable disease. And of course, the COURAGE trial demonstrated no incremental advantage of PCI on outcomes, other than angina-related quality of life. This suggested that a trial of optimal medical therapy in your patients is indeed warranted before PCI. Now, 3 years after COURAGE was published, researchers report in JAMA that registry data indicate that less than half of these patients are indeed receiving optimal medical therapy before PCI, and only 1/3 are not receiving OMT at discharge following PCI. This study was a huge undertaking. 500,000 patients were included. Before the COURAGE trial, the rate of optimal medical therapy at the time of PCI was 43.5%, and although the increase in the proportion of patients receiving optimal medical therapy before PCI after the COURAGE trial was statistically significantly higher at 44.7%, this is of little clinical significance. Thus, less than half of patients undergoing PCI are receiving optimal medical therapy before the procedure, despite the guideline-based recommendations to maximize that therapy, and the clinical logic of doing so before PCI so that the need for additional symptom relief from revascularization might be appreciated. After publication of the COURAGE trial, little change in this practice pattern was observed. The overall rate of optimal medical therapy after PCI was 63.5%, before the COURAGE trial and 66% after COURAGE, and there is essentially no change there either. Clinicians did increase the use of medical therapy before discharge, with antiplatelet agents being almost universally applied, but almost 1/3 of patients were not treated optimally. Well, what does all this mean? Are we all so set in our ways that COURAGE had no impact, or did we simply not believe it? I don't think either is correct. We know that symptoms are improved with PCI, and patients don't enjoy having chest pain. Part of our job is to make patients feel better. I like to say that angioplasty in stable patients never saved a life in its life, but PCI does improve quality of life, and I suspect that is the real driver of the use of PCI for our patients. Nevertheless, the findings suggest a significant opportunity for improvement in caring for patients with stable angina, and emphasize that the COURAGE trial had a limited effect on routine clinical practice. I'm Peter Block, and this is a CardioSource Heart Minute.